Hi, everybody. Welcome. I'm Dr. Logeman. I'm a neuropsychologist at On With Life. I not only do neuropsychological evaluations, but I also work with our outpatient concussion clinic, which is what they've asked me to present on today. And we're going to talk about the importance of returning to activity and purpose following concussion. All right, so just as a note, I have my notes here, but the presentation here. So if I'm going back and forth, that's because I'm looking at two screens. I'm a salaried employee On With Life, but I have no other financial disclosures to talk about. We're going to talk a lot today about the mechanism of injury and other pathways that contribute to concussion and delayed recovery concussion. And then we'll talk about interventions and specifically dysautonomia, cerebral blood flow, and then planning and pacing and other interventions for delayed recovery concussion and how to return to activity and return to purpose. Okay, so we are going to talk about concussion, which when we think about classification of head injuries, we start here at this number one, bumped head, no visible damage, all the way to death. And we have severe traumatic brain injury and moderate traumatic brain injury. And we're going to talk about this sort of area right here, which includes mild concussion with or without loss of consciousness, all the way up through a complicated mild traumatic brain injury or concussion, which it's called complicated because it has findings on imaging. So what is a concussion? A concussion is a bump, blow, or jolt to the head or neck that causes the brain to move inside the skull. The analogy that I always use is the brain is like a jelly mold sitting in a bowl full of water. And if we move it too quickly, that jelly mold in that water is going to bounce against the edges of the bowl. And our brain's kind of the same way because it's sitting in all that cerebral spinal fluid. So anything that can cause the brain to sort of like jolt or move within that jelly bowl can cause an injury, and that can include, mechanical injuries such as like a blow to the face. It can come from falls, motor vehicle collisions. There's a lot of sports injuries, and in fact, a lot of our research comes out of the sports injury field. But then also, a lot of our research on concussion also comes out of military injuries, which also include blast injuries. And that sudden movement in our bowl full of water can cause that brain to sort of like distort, including bouncing or twisting, which might not show up on pictures, but at the neuronal level, it causes some neurons to change, like the cell wall to change in the neurons, which can then result in chemical changes, and then as a result, results in functional changes. Concussions are not always associated with loss of consciousness or extreme injuries, and concussion ultimately is an injury that affects the way the brain works or functions. When we're thinking about recovery timeline, we're thinking about 4 to 6 weeks. In children is considered the acute recovery, with about 70% resolving in 1 to 3 months, whereas adult 80% of concussions resolve in those first 10 to 14 days. And research shows anywhere from 10 to 20% persists past that 4 weeks of injury. The delayed recovery phase in children is after 8 to 10 weeks, and in adults, it's considered after 4 weeks post-injury. And we call it delayed recovery concussion. However, it can go by a lot of other different names: prolonged recovery, persistent concussion, persistent post-concussive symptoms, post-concussive syndrome. It's called a lot of different things. But you're going to hear me use that delayed recovery terminology most today. So I really want to delve into the mechanism of injury, because if you can understand this, you can understand why we use the interventions that we use. So we're going to go back to some of the basic science here, which is my favorite, but I tend to get excited about it and talk about it quite quickly. So like I mentioned before, we have types of mechanics that can result in concussion, including that direct impact, that acceleration, deceleration, as you can see here. So that direct impact, acceleration, deceleration, such as like in a car accident, and then a blast injury, such as in our military or service people. And as a result, we have this diffuse axonal injury or dysfunction of the axons. And so what happens is our brain is made up of gray matter and white matter, and they are parts of the same neuron, but they have different densities because of their makeup. And so you can see here, we have our nucleus and then our axon with our myelin sheath, and our gray matter simplistically is made up of a bunch of these different sort of nucleus and cell bodies, whereas our white matter is made up of these myelin sheaths. And as you can see with the diffuse axonal injury is that because of the different densities between the gray matter and the white matter, they move with that injury at different rates and in different ways. And so you can get this torn axon here. This is the more severe sort of injuries. You can get this torn axon. Or another way to look at it is you have a normal functioning neuron here, and you have those axon, which then terminates on the neuron B here. So the signal travels down and it releases the neurotransmitter here, where in a concussion, because we've had that axonal shearing, shearing is one way. Another way is that the neuronal cell wall, going back to high school biology here, that cell wall made up of that phospholipid bilayer, the integrity of that bilayer is compromised due to the bouncing or the shearing or the tearing. So then as a result, we have calcium that rushes into the cell and potassium that rushes out of that cell. And so you have different electrical valences in versus inside versus outside than what would be at a normal resting state. And so then as a result, the neuron can't send its electrical signal down that axon. And so because it can't send that electrical impulse down that axon, you get a weird sort of like release of neurotransmitters down here, because the cell is like, I have no idea what's going on, and just release everything. And so it just releases everything. And you can get some excitotoxicity at sort of neuron B. And so what can happen is there's two different things that are sort of happening here. You get the energy crisis, which is because we have that potassium rushing out and that calcium rushing in. That neuron can't fire its electrical impulse. And so it actually requires more energy for that neuron to send that electrical signal down the axon, because the protein pumps have to work that much harder to get that electrical balance back to at a level where it can send that electrical impulse. So it takes more energy to do the same work it used to do easily before. Okay, so then we also have increased glutamate from the cell. So not only are we having a weird signal going down the axon, but now the signal is being sort of muted or hidden within all this sort of glutamate transmission. So we have to think about both of those things when we think about sort of concussion, the symptomology, and the rehabilitation. So with that, you can see this ion influx, that's the potassium and the calcium that I was talking about. Those can be related to that migraine headache, the photophobia and the phonophobia, that energy crisis, or that new need for the neuron to use more energy to do the same thing it used to do easily before, makes you very vulnerable to that second injury. That axonal injury that I was talking about, that impaired ability to send the signal down the axon, results in impaired cognition, slowed processing, and slowed reaction time. And that impaired neuronal transmission due to glutamate results in impaired cognition, slowed processing, and slowed reaction time. So that's sort of like one piece of the puzzle, is this we call it the metabolic cascade, and result in energy crisis. The other thing that we need to think about is a lot of the research is showing that there's inadequate cerebral blood flow to the brain following an injury, which then can only exacerbate that energy crisis that I was talking about. So we kind of have this Jenga game of like injury on top of like things that exacerbate that injury. So you can see here, down below, this is a study done in 17 athletes looking at cerebral blood flow 1 day, 1 week, and 1 month post injury. This is in JAMA Neurology, in case you're interested in it. And when compared to healthy athletes over time, they found a reduced blood flow in the insular cortex right here, as well as the superior temporal cortex. And they found that with prolonged symptoms, that there was reduced cerebral blood flow to the mid-insular cortex at 1 month, which was also correlated with increased psychiatric symptoms. So overall, and this is just one of the studies that I picked, there's another study out there that looked at cerebral blood flow, and it found that overall that the bifrontal and temporal lobes had decreased cerebral blood flow, which then can exacerbate symptoms, right? So if you have an increased metabolic demand at the neuronal level, but you don't have the blood supply to meet that demand, then you can get this sort of, self-propelling symptomatology. Okay, and symptoms can include, usually within the first 24 hours, you see headache and dizziness. These tend to be the ones that sort of persist past that acute phase into that delayed recovery phase. But you can also see nausea, vomiting, drowsiness, blurred vision. And then these other ones can pop up in that sort of like acute to delayed recovery phase, include irritability, anxiety, depression, poor memory, poor concentration, insomnia, fatigue, and visual and auditory complaints. Again, we're going to go back. So those first, that, because of the metabolic crisis in the first, first week or 10 to 14 days, you have to have a different sort of like approach to symptomology and recovery than you do in the delayed recovery phase. What does the delayed recovery phase look like? Good question. So the delayed recovery phase, it is more non-specific than the acute phase. And when we get into that delayed recovery phase, it can actually be quite challenging, because not only do we have the initial metabolic cascade that we're coping with, but then we're also, and this reduced cerebral blood flow, but then we're also coping with all of the things that sort of come up as a secondary process to those things. So, headaches, deconditioning is a great example of that, but then depression, anxiety as a result of your symptoms. And so it can be really challenging when we're doing interventions and talking about diagnoses to parse apart, what is true pure concussion pathophysiology and what is a secondary process. I saw a lot of studies that many of those who are symptomatic at 1 month will continue to be symptomatic at 1 year. And I think just to highlight this, in this Walya study, they looked at 59 of patients with TBI, met criteria for what they call post-concussive syndrome at 1 month, and 39% meant that at 1 year. I've also seen studies as high as 59% continue to experience some sort of like PCS symptoms at 1 year. And I think this is clouded by the fact that 31% of healthy controls in the study also met criteria for post-concussive syndrome, even though they didn't actually have a concussion. So I think that goes to show you just how non-specific the PCS symptoms are. And I think this also highlights, there is a lot of overlap between concussion, stress, anxiety, depression, and PTSD. And at some point, interventions become less about concussion specific and more about you're experiencing the symptom, how do we address the symptom regardless of the etiology and where it came from? And that can be a little bit of a mind shift, both from the patient, person served, and also the provider. Okay, so one of the mechanisms in delayed recovery symptomatology is this thing called autonomic dysfunction. So colloquially, or straight lingo, everyone's heard of the fight, flight, freeze, or fawn, and the rest digest, sex. And so in concussion, what can happen as a result of the what can happen is that these things are inappropriately regulated by the brain. And so you can be, and so these are complementary sort of systems, right? If our fight, flight, freeze, or fawn response is on, then our rest, digest, sex system cannot also be on. So it's sort of this like give and take. And so in people with concussion, the brain can have a hard time sort of regulating the on of this one and the off of this one, and then regulating the off of the sympathetic nervous system and the on of the parasympathetic nervous system. And so they, a lot of the research shows that this reduced cerebral blood flow is a result of this poor sort of regulation of the autonomic nervous system. And so one piece of intervention is, how do we better regulate this system, right? Because it's a teeter-totter, right? We not only have to turn off the sympathetic nervous system and turn on the parasympathetic nervous system. Okay. So individuals with concussion demonstrate altered autonomic functioning, which we also assess as the cerebral blood flow, which we talked about in the acute phase. And you can see here, looking at that cerebral blood flow, people who have recovered from a concussion have increased blood flow in certain areas during certain activation sort of tasks. Excuse me, but people who are still experiencing delayed recovery symptoms have inappropriate activation. As you can see here, there's more activation in the occipital lobe, but then also you can see increased activation in that frontal temporal, sort of like frontal temporal parietal areas. So they're recruiting more areas of the brain in order to do the things that people in the recovered are recruiting less areas, which then also speaks to this energy crisis, right? They're recruiting more areas of the brain using more glucose, using more oxygen in order to do the things that people who have recovered are using less energy to do. Everyone on board so far? Okay. Okay, so there are other components of delayed recovery concussion. We just talked about the physiological one, which is that inappropriate regulation of the autonomic nervous system. And one way that we can assess this is this exercise intolerance. So how well do they do with physical exertion? And if they have symptoms that increase with physical exertion, that likely represents global dysfunction. Again, that autonomic dysregulation of the brain. You can also have vestibular ocular sort of delayed recovery symptoms, which include saccades and convergence insufficiencies, and likely is not representative of that metabolic cascade and or the autonomic dysfunction. And then you can have cervicogenic stuff, which is of the cervical spine and surrounding musculature. We see this a lot in our whiplash, but that can contribute to things like headache and pain, and then also irritability. If you're walking around with neck pain all the time, you're not going to be the most fun person to be around. And then also we see this other sort of aspect of delayed recovery concussion, specifically mood-related stuff. So if people are coming in with premorbid mood or premorbid cognitive findings, you're likely going to see an exacerbation and continuation of that in delayed recovery concussion. And usually in these people, especially in my clinical experience, we don't see a lot of stuff on formalized testing, meaning that if we can distract people or engage people in a certain way, we don't see a lot of findings on physical, cervicogenic or vestibular testing, or even cognitive testing with speech therapy. But then once you sort of like pull their attention towards it, then you see an increase in these symptoms. And so that tells us something about sort of like the rehabilitation and sort of the path that we have to go for rehabilitation. Okay. So in summary, we have the acute phase that has the metabolic cascade resulting in an energy crisis. And we also have the reduced cerebral blood flow and dysautonomia, which then likely exacerbate the sort of like metabolic cascade and energy crisis. And then in the delayed recovery phase, we have the reduced cerebral blood flow and the dysautonomia. We also have mechanisms as a result of the secondary processes. And then we also have the pre-injury factors play a greater sort of determining are a bigger variable with regards to return to activity, return to function once we enter that delayed recovery phase. So what does active rehabilitation of concussion look like? across the board, everything that I've seen in the research shows, one, using a biopsychosocial model approach. Two is having an initial period of rest for 24 to 48 hours following acute injury. And this includes physical rest and cognitive rest. I would add emotional rest in there as well. But what does that look like? That's going to depend on the person, and whether or not that's actually achievable is something different. And then the research also becomes a little bit more sort of vague when it comes to like relative rest versus absolute rest. And we'll talk a little bit about what this means later. And then consistently, the research shows that rest greater than 3 days is probably not helpful. And I actually, I was doing a lot of reading. A lot of this research comes out of like kids and adolescent athletes. And one of the studies that I read found that rest greater than 6 days, like prescribed rest greater than 6 days, actually prolongs symptoms significantly longer, even more so than care is normal or care is usual. So this prescribed rest, 24 to 48 hours, seems to be sort of the optimal amount of time for rest. This is a problem, and I think people can see this coming from a mile away, is that how many people actually get medical care in the first 24 to 48 hours, unless you're a student or an athlete or a service member. Very few people can actually get in, and that can be problematic, and we'll talk about what that means. And then following that period of rest of 24 to 48 hours, you want to have a gradual return to activity, but you want that activity to be kept at kind of like sub-threshold, meaning not at a level where we have a severe exacerbation of symptoms. And regardless of where they are in their recovery, we want to get return to activity and return to purpose. That's the big goal, because likely where we come in as clinicians is going to be after this initial 24 to 48 hours. All right. Next slide. Okay, so what can we do about it? First thing is first is, as providers, we can be educated and well trained. And so what this study looked at, this was a study done with service members, and it looked at service members who had had a concussion, and they looked at the clinically elevated symptom level using the neurobehavioral symptom inventory. And so for 72 hours, you can see, this is receiving the care as usual, and this is receiving care from a provider who is trained in overseeing a gradual return to activity. And you can see 72 hours to 1 week, again, that acute phase, there's a significant difference here, but there's still, a large number of symptoms. That 1 month follow-up becomes huge with return, if you have that care as usual versus someone who is overseeing a gradual return to activity. You can see this huge drop in reported symptoms here. So again, highlighting that important to return to activity, whatever that activity may look like, but doing it with a supervised professional, or doing under the supervision of a well-trained professional. Looking at education of patients, only about 50% of patients actually receive education at the time of their diagnosis, and even fewer receive positive expectations for recovery, which I think is huge. That from that same study, we were looking at people who all they received was a handout that included sort of like interventions and a gradual return to activity. And you can see here with the TBI with a mild intervention or that handout, you have significantly less symptoms, particularly in sleep and anxiety. And then I would also add headache versus people who didn't receive any education. So that education, especially that education early, is so important. Furthering this, I looked at this study. This is done in a bunch of service members who received initial education about rest versus activity, and you can see here they increased their level of activity with their decrease in sort of symptom level. However, and this was buried in a table that was not visually pleasing at all, but as said in the study, we found that greater belief that rest influences concussion influences concussion recovery was associated with a larger increase in activity level later over time, but only among those who received education around the time of their injury. So again, this highlights not only the return to activity, but that receiving that supervision of return to activity with an educated professional. Okay, so when we think about gradual return to activity, On With Life thinks about two really important things. The first important thing is we want you to get back to purpose. We want you to get back to what brings you joy and sometimes what you have to do, including work. And then this is all sort of centered around this idea of we want to expose you to symptoms, sort of like that sub-threshold level, exposing you to symptoms with the education and thought restructuring to help better manage those symptoms. So we have a graduated exposure paradigm combined with planning and pacing to repeat and sort of like improve that cerebral blood flow, improve that dysautonomia, and sort of provide that thought restructuring. And usually what happens when we have this is that people tend to feel slightly worse at the beginning. You tend to have an exacerbation of symptoms. And that's usually only a very small part of recovery. Usually that gets better if people adhere to sort of this plan. And some of the first things that you can do is you can figure out how patients respond to return to activity. And they tend to fall into these two categories. And in fact, I don't have, I really highly recommend this one, which I don't know if people can see. Oh, you can't see it. I'll put it in the notes, but it's called The Feasibility of Concussion Rehabilitation Approaches Tailored to Psychological Coping Styles, a Randomized Trial. And inherent in this sort of like approach is pulling a lot of theory and approaches from chronic pain populations. And so this fear avoidance sort of understanding of response to symptoms is coming from chronic pain. And what it means is patients who tend to engage in this fear avoidance behaviors, they have negative appraisals of pain and its consequences, which then leads to avoidance of activities, meaning that they have a flare-up of symptoms and they mean that something is wrong. And so then they don't engage in, or they don't do whatever activity they were doing, which then leads to further deconditioning and inactivity syndromes. Okay, so that's sort of like one arm of like patient population. The other arm is that you can get these patients that have endurance behaviors, or we call them the boom and bust cycles, where they tend to push through the pain. They tend to do things even though they are feeling pain or have a lot of symptoms, or they try and put everything on a good day. So they wake up feeling great, and then they put everything into it, and then they have flare-ups and then have to have prolonged periods of rest. And so what the study does that I just showed you is that it gave sort of self-report measures, and it looked at which sort of category do patients fall into, and then providing specific strategies tailored to which way they tend to lean, that fear avoidance or endurance behaviors. And you actually see an improvement in symptoms overall, which is again showing that tailoring these interventions for those psychological coping styles is really important. And it's pulling in that medical model of like increased activity with that psychological component of how do we approach pain? How do we approach how do we interpret a flare-up or symptom exacerbation? This is those two things sort of put into pictures. Okay, so on this side we have that fear avoidance cycle, and I included the psychological component of that as well, right? So on the physical side we have symptoms, and then we have activity avoidance, which then leads to progressive deconditioning. And then when you go into, because you're deconditioned, when you go to do something, then you have this increase or flare-up of symptoms, which then leads to further activity avoidance and then further deconditioning, which then means we have more symptoms, and the cycle sort of repeats. But then considering the psychological side, we have symptoms, we have anger, we have our initial reaction to those symptoms, anger, anxiety, depression, etc., which leads to impoverished mood, such as furthering depression and anxiety, which then can actually impact our perception of symptoms, right? When we're depressed, we're more likely to experience pain as more painful, or experience pain in a different way, which then can lead to increased symptoms. Over here, we have the boom and bust cycle. Again, a good day, we're trying to pack it all in, can have overactivity, which can then lead to increased symptoms and the need for prolonged rest. And then once you're rested, then you have a good day, which then continues the cycle all over again. And this is where sort of the psychological and emotional regulation thought reframing sort of comes into play, is that when we have those thoughts and feelings like on that sort of like psychological process side of things, we have thoughts and emotions about it, which can then influence our behaviors, right? So we talked about the fear avoidance tend to catastrophize, which would be over here, which is sort of like blowing things up and out of proportion or misinterpreting things, jumping to conclusions. So like, I have a headache, so I must still be sick, or I have a headache, it must still be my concussion, versus you could have a headache because you're stressed or didn't eat or need more water or whatever, right? So it's important to sort of look at some of those automatic thoughts that are contributing to health-related behaviors. Bringing it all together. Okay, so talking about planning and pacing and this gradual return to activity, we want to avoid this overuse syndromes, which is that packing it all in, that boom and bust cycle. And we want to avoid that inactivity syndromes or that prolonged rest, right? We want to be here at sort of this like normal level. And here, if we're overusing it, we have to pace down. And if we're here in that inactivity or prolonged rest, we have to pace up. That doesn't mean that if you're here, you don't have to pace. No, especially if someone's still coping with an injury, you still have to learn how to plan and pace your day in order to sort of remain here without falling into an overuse syndrome or inactivity syndrome. And again, we are doing this because we want to help the body learn to sort of regulate the turning off of the sympathetic nervous system and turning on of that parasympathetic nervous system. Now, how do we do planning and pacing? It is probably one of the more challenging things that we teach people, that we teach our person served here. Excuse me. What we see here is that usually people come to us with this sort of like a graph of activity over time and then time spent in the symptom zone. And you can see here, you know, there's a lot of time spent in the symptom zone, and anything that's like sort of on the down here is rest. And so we see a lot of time in rest, especially down here. And our goal is to get them looking something like this, right? And so, yes, we're going to have an increase of symptoms, and you might even experience some symptoms, but you can see with appropriate levels of rest that you can actually spend more time being active, right? And our whole goal is to sort of like, if we work at that subclinical threshold of symptoms, meaning that you don't have a headache, but you could feel one coming on, sort of like resting before you have a headache, or, you know, icing before you have pain, or you know, taking a cognitive break before you feel like you need one. By doing that, we're sort of like bumping up that symptom onset level, right? If we engage in activity and we get to here and then we rest, right? Then we're sort of like just bumping this guy up as we sort of like engage in that activity. And this is ultimately what we want that graph to look like. Yeah, you might have some symptoms, but again, 31% of people endorse concussion related or delayed recovery symptoms, even though they've never had a concussion, right? So yes, you're going to have some symptoms, but you can see that they spend a lot more time sort of like engaged in doing life and doing the things that they want to do. Planning and again, this is so challenging to teach in just like a 45-minute session, but individuals with overactivity need to pace down. Individuals with underactivity need to pace up. Pacing is not the same as rest, right? We need rest to be a part of pacing, but it's not resting all the time, right? It needs to be sort of a balance between activity and rest. And activity can be physical activity, cognitive activity, or emotional activity, and rest can be absolute or relative rest, right? And pacing is not being active until the point of severe symptoms. That's the boom and bust cycle. And pacing is not based on task completion. We'll see a lot where it's like a lot of people where they're like, oh, well, I'll just, I don't know, clean my room and then I'll take a rest. Well, based on your symptoms, you might need to take a rest before you finish cleaning your room. So why don't we do, 10 minutes and see how much you can get done and then take a rest. So it's individual based. Excuse me. Okay, so develop a plan and determine a beginning tolerance level, and then work up from there. And you can break up your tasks, incorporating both rest and relative rest. So relative rest is alternating, well, absolute rest is, going to a quiet room and taking a nap, right? That's absolute rest. Relative rest is where you're engaging in a different activity, such as like a physical activity. You then might engage in a cognitive activity, or alternating different muscles, right? So, if you're walking a lot, you might use your arms. You might go and, like, I don't know, work at a desk or something. So you want to incorporate both relative rest and absolute rest. And the goal of pacing is to retrain that nervous system to participate in activities without exacerbating symptoms. What can you do in the clinic? Again, the important thing is to provide education and set positive expectations for recovery, providing education not only about the nature of the injury, but what's going on, and then why we're doing the things that we're doing. And then one of the best things that you can do is identify return to purpose, what is important to them. It increases their salience, so it increases the generalizability from what you're doing in office to outside of that, as well as follow through. And we sort of when we think about return to activity, we break those activities up into 3 different sort of buckets: self-care, productivity, and leisure. And all of these are non-negotiables. You have to engage in all of these. And so productivity, that's probably the most self-explanatory. These are the things that need to be done: work, childcare, bills, and you can usually tell that their productivity because they have some sort of like external deadline or external sort of expectation. Self-care is a non-negotiable. Self-care is not chocolates. Self-care is doing the things that you need to do to provide basic care for your body and yourself. And this might look different in different environments. So for example, mental health walks, getting up, stretching your legs, taking a 10 to 15 minute walk, that is self-care. And you might need to do that more at work than you do at home. Okay. And that's a non-negotiable. So then you have to plan that into your day. Another thing that fits into that sort of self-care bucket would be things like opening and closing tasks. So like, what do you do to get yourself up and moving in the day? And what do you do to help yourself sort of calm down for the day, which then also then bleeds into sort of sleep hygiene techniques as well. Leisure activities are things that are done by choice. They're free from obligation and they give enjoyment and pleasure. Again, these are non-negotiables because they can help sort of turn on that parasympathetic nervous system to help decrease that sympathetic nervous system. So, reading, crafting, working out, tinkering on stuff in the garage, completing projects, finding those leisure activities can be a gateway in sort of that return to purpose. We talked about the psychological interventions, find out what's important to them, take some time and understand how they fit into that fear and avoidance or boom and bust cycle, respond to that using sort of like the thought restructuring or the cognitive behavioral interventions. And then physical therapy and occupational therapy can also address those other pieces of delayed recovery concussion that we didn't really talk about, including the cervicogenic pain and vestibular and ocular motor interventions. Another thing that we can do for return to activity is aerobic exercise in clinic. I think this is a great idea because you can have direct modeling of planning and pacing techniques. So as they engage in aerobic exercise, if they have an increase in symptoms, then immediately show them how to pace down, and then potentially when they're pacing down, how to engage in relative rest. So, if they're, running on the treadmill for 3 minutes, they have an increase in symptoms, bring it down and let's do a mindful minute together. So you're pacing down and doing relative rest by engaging in mindfulness, which then increases that parasympathetic nervous system activation. And this was a randomized control study that just came out in JAMA Neurology, which looked at aerobic exercise versus stretching in adolescent athletes. And you can see that with aerobic exercise, you can see a decrease in post-concussive symptoms versus just that the stretching group. And that goes back to that retraining the brain how to regulate cerebral blood flow. Right. So as we're engaging in autonomic, in aerobic exercise, especially aerobic exercise that's kind of at that sub threshold level, we're sort of teaching the brain and teaching the body how to better regulate that cerebral blood flow so you have less symptoms. This is a great article. This came out in 2019, which sort of like outlines all the things that I've talked about, including your period of initial rest, how to gradually increase your activity, full reactivity. I really like these 4 Ps that can help you gradually increase your activity, which includes prioritizing, planning, pacing, which we've talked a lot about, and then position, thinking about where you are in the world and how you can sort of modify your environment to help best you recover. All right, last slide. Thank you for hanging in there. So in summary, we've got acute and delayed recovery that have different sort of like etiological or biological considerations that contribute to symptom presentation. Acute, we have that metabolic cascade and energy crisis. Delayed recovery, we have that pre-injury factor, factors related to the injury, psychiatric status, but across both of them, we have this sort of like dysautonomia and poor regulation of cerebral blood flow. And then regardless of where they are in their activity, particularly as they come to us as professionals, we want to push that return to activity in a graduated fashion and pushing that engaging in purposeful activities, and then consider the biopsychosocial model. Are we looking at some sort of fear avoidance behaviors, or are we looking at a boom and bust cycle? Okay, thank you guys.